Okay, every time I say I'm going to try to make it short, the videos have been somehow getting longer and longer, so I'm just not going to say anything. First of all, shout out Paulina for the study guide again. Last one was great, especially for the anatomy part, and then this one has everything that'll answer the study guide topics and has additional information that provides like the big picture for all of this stuff. I went over the 9 lectures for this exam, and this study guide is, I think, more than enough to cover all of the stuff that she needs. It never hurts to obviously like skim over the lecture stuff as well. And there's also the document that goes over things that she said would be exam questions. So I would definitely look over that as well. If you haven't done the lab stuff yet, I would recommend doing the lab stuff first, then the study guide, because this exam is sort of like the complete opposite of last exam. Last exam was more of like, what is this muscle? What does it do? What happens if the nerve that innervates it gets damaged here versus if it gets damaged at this other location? There was all these clinical stuff, whereas here you don't really have that. Most of the stuff is just like, where is this located? What branches off of it? What does it supply? What is anterior to it, posterior to it, the specific location, whether it's in the abdomen, the quadrants, or the mediastinums in the thoracic area. So I would definitely recommend doing the lab stuff first and then doing this part. For the embryo questions, we're just going to let Jesus take the wheel on that one. Embryo never clicks in my head, so just maybe skim the lectures, skim whatever documents people post or material, and hope for the best. Okay, so lymphatic drainage of the breast, the areola, which is literally like the circular area around the nipple. This has hair, which is unlike the nipples. Nipples have no hair or sweat glands. This does, so it can provide like lubrication. Because of the hair and the sebaceous glands. It enlarges during pregnancy, and these are going to be important when it comes to lymphatic drainage. So, when we're talking about the breast, first of all, if you remember, the dermatome for the breast was T4. Specifically, the nipple was at T4. So it makes sense that within that range, you will have arteries that provide blood supply. So second, third, and fourth. That's the key one, the fourth. So that's the range where you get your blood supply. And also the nerve supply is 4th to 6th. So they both include 4th. They're within that range. So if you remember the dermatome, you can kind of work your way around what blood vessels and nerves will supply those areas. Now, most of the lymphatics in the breast will go to the axillary lymph nodes. So these are your axillary lymph nodes, all of these right here. If you look at the breast, different locations will drain in different spots. However, most will go to the axillary lymph nodes. So that's the key one, the 75%. An exam question that she said she could ask is the upper outer, so this is like the upper lateral quadrant, will drain where, and specifically in the pectoral lymph nodes, which are axillary lymph nodes. So these pectoral / anterior lymph nodes are right here, so it makes sense that something from this upper quadrant will go into here. The medial breast quadrants, so look at where the breast is. This is the medial part. So this is what's closest to it. So medial is going to drain in the parasternal. Para means like next to or besides. Sternal, sternum. This is your sternum in the middle. So parasternal lymph nodes right here. And then the inferior ones, so the inferior quadrant will go to the abdominal lymph nodes. So you'll have lower abdominal lymph nodes that come up to like this level. So that's where most of the lymphatics are for the breast. The key thing is the axillary ones, which drain more than 75%. Now, for sternal angle and significance, the sternal angle is important because that's where you could technically feel like the first rib. There's also a lot of things that happen behind the sternal angle that we'll talk about when we get to like the mediastinum stuff. So if you look at this first rib over here, the clavicle covers it to the point where it's really hard to palpate it or to touch it on someone's body. But the second rib is way more open, and that's the one that is attached to the sternal angle. So this is the manubrium, or top part of the sternum. This right here is the sternal angle. So the second rib is easily palpable because costal cartilages articulate with the sternum at the sternal angle, located at the junction of the manubrium and the body of the sternum. This top part is the manubrium. This is the body of the sternum. So their junction right here is the sternal angle. And it's a reference for identifying ribs. So you know that's where rib number 2 is. If you go to the sternal angle and you go a rib down, then you're at rib number 3, and so on. It's also important because it will separate the superior and inferior mediastinums that we were just talking about. And it marks the T4, T5 vertebral level. So what that means is this, if you look at the way the ribs are, they don't just like go straight to the back like that. They actually curve up. So the second rib would be at a much higher level than T2. If you went straight behind this, you would be at the T4, T5 vertebral level at the back. So that's why it says T4, T5, even though the sternal angle is technically on rib 2. Now for the superior, inferior mediastinums, the sternal angle will separate. Above the sternal angle would be superior, and then below would be inferior. The lowest part we go, so the inferior will end at the diaphragm. So we're talking about from sternal angle to diaphragm. The superior will start at the sternal angle, and it will go up to this thing called the superior thoracic aperture. So that just means this top closed part. So all the things that go between here, and there are a lot of things that go there. And we'll see those structures when we get to the mediastinum part. Now, costodiaphragmatic recess. So you can see between costo, or like rib stuff, diaphragmatic or diaphragm stuff, you can see this blue space right here. This is a space that usually when you inhale, the lungs will fill this space. And then when you exhale, they go back up. Now, if that space is filled with something it shouldn't be filled with, whether it's fluid or blood or anything like that, then obviously you're going to have problems because now your lungs can't inhale fully, and that's going to disrupt many parts of your body because then you're not getting the full oxygen you need to get in, blood's not getting oxygenated, it's not getting transported properly, and all that stuff. So what you do is you will do something called a thoracentesis. Before we do that, if you notice, the costodiaphragmatic recess here is at a higher level compared to here, so it drops because of the shape of the lung. This is the diaphragmatic surface of the lung on the bottom. So at the mid-axillary line, so axilla just means armpit. Remember when we talked about the axilla and the lymph nodes for the breast? So axilla is just armpit. You can kind of see here, this is where the lymph nodes are. So mid-axillary line would be, if your armpit is like right here or something, it would be like this. This is mid-axillary line, where your armpit is. Mid-clavicular line is the middle of your clavicle, so that's like right here. You can tell that this is a higher level than this diaphragmatic recess. So mid-clavicular is around ribs 6 and 8, whereas mid-axillary is around ribs 8 and 10. And then if you kept going to the back, to your actual vertebra would drop even more. So the back would be 10 to 12. So the highest would be the mid-clavicular, then mid-axillary, and then the paravertebral. Para, remember we said next to, para next to, vertebra next to your vertebrae in the back. Now, if there is something in there, like fluid or whatever, we want to drain that. So we do something called a thoracentesis. We really do not want to hit the intercostal nerve and vessels. So inter means, we said para means next to. So para, we said, is besides / next to. Inter always means between. So like in the heart, when we're talking about the septum between the right ventricle and the left ventricle, this is inter, because between, these are ventricles, ventricular septum. So that's just an example of when we use inter. So here, if we are intercostal between ribs, costals, ribs, nerves and vessels. So between your ribs, you'll have these nerves and vessels. We don't want to hit them, so we go towards like the middle area. So you place it at the 9th intercostal space, mid-axillary line, so like middle of like your armpit, and you want them to fully expire or exhale. This is important. If they are fully inhaled, this would drop because the lung needs to fully expand. If you poke it when they're fully inhaled, you will poke through the lung. So you need them to fully expire, and then you go to the 9th intercostal space. You also have to angle it upward, because if you just went straight across like this, now you just hit your diaphragm and you hit your liver. So you created another problem instead of just solving the original one. So that's how you drain fluid. 9th intercostal space, mid-axillary line, then you aim it a little up. Now, when we're talking about lungs, there's a difference between the right and left lungs. Each lung has an apex, or the top. And a base, or the bottom, / diaphragmatic part. The bottom part that's going to be right next to the diaphragm, or above the diaphragm. They also have costal, mediastinal, and diaphragmatic surfaces. So if this is a lung, for example, this front part, anterior, where your ribs will go, is your costal. The bottom part that sits on your diaphragm is your diaphragmatic. And the part that's middle, or where your heart is looking at, if your heart had eyes and was looking to its right, it would see the middle. That's your mediastinal surface. Then anterior border would be this border right here. Behind it would be posterior, because it's a 3D thing. And then bottom would be inferior. So these are similar between both lungs. Now, this says, so cadaveric lungs, so the lungs for cadavers or donors are going to be different. Obviously, going to be firm, discolored, and all that stuff compared to healthy people, because they're not functioning properly, they're not moving, no blood flow, oxygen, all that stuff. Right lung has 3 lobes. Left lung has 2. And the way to remember it is when we talk about the heart, The right tricuspid valve has 3 valves or cusps, and the left has 2. So they follow that same trend. The right lung is going to be larger and heavier, but it's shorter, and the reason for that is because the right diaphragm is higher. So if the right diaphragm is higher up, then that makes the right lung a little shorter than the left. And then the reason it's wider is because the left lung has the left ventricle pushing on it, so it's making it narrower, and we'll see that when we get to like the impressions. And it says that right here, heart bulges more to the left, and then right dome diaphragm is higher. The right lung does not have a cardiac notch, unlike the left. So remember, here we're still talking about all of this stuff's for the right lung. The right main bronchus is wider, shorter, and the key thing here is it's more vertical. This is why when kids swallow foreign objects, like a toy or whatever, it usually gets stuck in right bronchus. It's because it's more vertical, so it has a quicker route to go down. Easier route to go down. Now, on the right lung. So, think about how the heart sits between the 2 lungs. If we're looking at this lung as if the heart had eyes and it's looking to its right. So we are in the position of the heart right now. We just turned right. So this is the front of the lung, anterior, and this is posterior. So ignore this other lung for now. If we're looking there, the parts of the heart that are going to make an imprint or an impression on this lung are this right here, the cardiac impression from the right atrium, and then on the right side of the heart you have your superior vena cava and your azygos vein, which drains into your superior vena cava, because those drain into your right atrium. So only on the right side will you see an impression or a groove for the superior vena cava. So you have your heart in the middle with your aorta, pulmonary trunk, and then here, so this is right atrium, right ventricle, left atrium would technically be like behind there, but let's say that, and then left ventricle. So this is your superior vena cava right here. It's on the right side. This has no business causing an imprint on the left lung. It'll only cause an imprint on the right lung because it's pushing against it. And then the azygos vein will come up and it'll drain into the superior vena cava. It arches when it drains into it. That's why this thing arches right here. So arches and then drains the superior vena cava. Behind all of this stuff, you have your esophagus that will be coming down. Now, on the right side, nothing covers your esophagus because your trachea, which is anterior or in front of your esophagus, already bifurcated, already split into a right main bronchus and a left main bronchus. So the trachea already split like this. So now nothing's behind or nothing's in front of the esophagus, so it gets this full impression right here. On the left side of the heart, you have, the left lung, left side of the heart, you'll have this left ventricle pushing into this. And it's such a big apex that it causes a much bigger cardiac impression compared to the other side. You can see this cardiac impression is way greater. This is because of the left ventricle. Now, This right here is the aorta. Your aorta will first ascend, then it'll arch, and then it'll descend. So these things, the arch and the descending part, are going to push on your lung and cause an impression. So the arch on the left lung is going to be the aortic arch. And then it's going to descend posterior. So your descending aorta impression will be posterior. This is also called, aka also known as, thoracic aorta. That just means descending, but we're still above the diaphragm. If we were below the diaphragm, it would be abdominal aorta, descending or abdominal. We're above the diaphragm, so it's descending or thoracic. So the key thing here is the azygous vein goes from back or posterior and then drains anteriorly into the SVC. The aorta will arch, it's ascending from the heart, it'll arch, then it'll go posterior. That's why you'll get the SVC impression on the anterior side, but the descending aorta impression on the posterior side. So for the left lung, this is anterior, this is posterior. For the right lung, this is posterior, this is anterior. Just imagine the heart is turning right and turning left to look at the lungs. Okay, so we talked about on the right lung, we talked about the esophageal impression, azygous, superior vena cava, and cardiac. Now left lung, similar, where we just said 2 lobes. We use the bicuspid, tricuspid thing to relate it. On the left lung, you also have 2 things. So right lung is, so this is right, this is left. This is your superior lobe, because that's 3 lobes. So superior, middle, and inferior. So these aren't cut properly, but this right here would be a middle lobe, or sorry, a horizontal fissure, and then this would be an oblique fissure. So imagine this whole thing is your superior lobe, this is your middle lobe, and this is your inferior lobe. This is the oblique fissure, and the one here is horizontal. So horizontal would separate superior from middle lobe, but oblique would separate superior from inferior and middle from inferior, because over here it's separating middle and inferior, and then higher here it's separating superior and inferior. On the left side, all you have is one fissure, which is an oblique. So look at the direction they're going in. Oblique is going to be more slanted, curved, whereas horizontal is more straight. But on the left lung, you have 2 key things. You have this thing that projects out like a tongue, which is why they call it lingula. And you have this cardiac notch. Remember when we said the apex of the heart like pushes in? This is the apex of the heart. So that's what creates this cardiac notch in here. You can also see how this is a narrower lung than this one, like we said before. So the right one is wider. And you can also see how the right diaphragm pushes a little higher than the left. So this drops lower, so the right lung is shorter. And I think that's everything that's important. We talked about left lung, cardiac, arch of aorta, descending or thoracic, and esophageal. Oh, on the left side, really quickly, the esophagus also pushes, but you can see that the aorta covers most of it. So you don't get this huge esophageal impression. You'll get a much smaller one because the aorta is covering this part of it. And then all of these things, so your IVs, inferior vena cava, your esophagus, your aorta, and your thoracic duct, will all pierce or go through the diaphragm at different levels. So the way you remember it is I ate 10 eggs at noon or at 12. So inferior vena cava goes through T8, esophagus goes through T10, and then aorta, technically it's thoracic aorta. It's thoracic until it pierces the diaphragm. Once it goes through the diaphragm and it goes into your abdomen, then it becomes abdominal aorta. So aorta and thoracic duct both go through T12. Now, parietal pleura and innervation. So we have something called a visceral pleura and a parietal pleura. Visceral is innermost, parietal is outermost. When we say visceral, this relates to organ. So when you look at a heart, what is on the heart that you cannot remove is visceral. So this is on organ, cannot remove. Parietal pleura is like the outside thing that's covering it. So whether it's like on the wall of the abdomen or on the wall of your thoracic area. So there's a space between those two. Visceral's on the organ, parietal would be the outermost part that is covering whatever it is that we need it to protect, so wherever it is in the body, whether it's in the abdomen or higher up. The key difference is that the visceral pleura does not, put this in red, so does not have any general sensation, is insensitive to pain. So visceral pleura will feel no pain, which is different than parietal pleura. Parietal pleura is very sensitive to pain because all of the sensory stuff that supply whatever organ or whatever is in that range will hit the parietal, but they will not hit the visceral. So parietal pleura has 4 things, and then based on like the names, you can tell what they do. So costal, we're talking about ribs, so internal surface of the thoracic wall. And you'll have intercostal nerves there between the ribs. Mediastinal is going to be in the mediastinum. And over there you have the phrenic nerve, which also does diaphragm. Diaphragmatic would be the domes of the diaphragm. Each hemidiaphragm, so each half, because there are 2 domes. And then this will get phrenic nerve innervation and peripheral part of the lower intercostal nerves, because the bottom part of your ribs is closest to the diaphragm, so they'll play a role. And the key thing here is if she asks what the nerve roots are, it's C3, C4, C5, keep the diaphragm alive. So the phrenic nerve roots, phrenic nerve are C3, C4, C5. And then you also have a cervical pleura, which is much higher up. It's going to be in the superior thoracic aperture, which is what we talked about earlier. It's like that top circle where that first like rib connects to the top of your sternum, which is the manubrium. That's the superior thoracic aperture. And higher up, that's also intercostal nerves. And then we just talked about where would a foreign body be lodged. Right main bronchus, because it's wider, shorter, but the key thing is it's more vertical as well. So it gives it a direct path. Now, these are the mediastinums. This is when we were talking about the sternal angle. So this is your sternal angle. Behind it, we create this line, and then we said at the end is like around T4, T5. Everything above is superior. Everything below is inferior. The inferior is the one that gets split into anterior, which is this purple, middle, and posterior. So, divided into superior and inferior through the sternal angle. And then all the way back to the junction of the 4th and 5th thoracic posteriorly. Inferior, we just said, gets split into anterior, middle, and posterior. The middle is the heart. So, if we want to talk about the anterior mediastinum's borders, for example, we know that the middle mediastinum is the heart. So for the anterior mediastinum, the highest part has to be the sternal angle because that's where it starts. So superior has to be sternal angle. Inferior has to be the diaphragm because we don't go lower than the diaphragm in the mediastinums. So inferior, diaphragm. Anterior would be your sternum because that's what's in front of it. And then posterior, so behind it, would be this yellow thing, which is the middle mediastinum, which is your heart. So that's what I was saying. If you kind of understand where things are located and what separates them, you don't have to sit and memorize all of this stuff. Just remember where it's located, what's around it, and all these things would make sense. Anterior. So this is what we're just talking about. Anterior mediastinum. So anteriorly would be the sternum, and then the muscles that are there. Posteriorly is going to be the heart. So you can have the pericardium, superior sternal angle, inferior diaphragm. Now, the boundaries for all of these, the lowest thing is going to be the diaphragm. The highest thing is going to be the superior thoracic aperture, which is all the way here. And then laterally, you'll have the pleura. And anteriorly, the most forward in front of you thing is the sternum. And whatever costal cartilages that join them. And then we already said posterior is going to be like your thoracic vertebrae. T4, T5 would be behind the sternal angle. So all the way up, technically from like T1 to T12 would be your posterior border. So superior mediastinum. Now we're talking about this green area right here. This will have things that are above the heart, and then other parts such as the thymus. So the thymus is a paired lymphoid organ, so you'll have one on each side, and it's in the superior mediastinum. The key thing about this is that after puberty, it undergoes gradual involution replaced by fat. So there isn't much use for it in adults. So it's actually larger in children. So larger in younger patients. It's actually so much larger that it'll actually dip into one of the inferior mediastinums, whereas in adults it stays in the superior mediastinum. The other thing is the stuff above the heart. So if this is your heart right here, above it you have your superior vena cava, so that goes into superior mediastinum. The arch of the aorta is also above it, because your aorta, first of all, ascends, so that's still within the heart range, but then the arch is over, and then it descends after that. When it descends, it goes posterior. So the posterior part is actually posterior mediastinum. So if we want to split this up, the ascending aorta, which is within the heart, is middle mediastinum. The arch is superior mediastinum, and then the descending or thoracic aorta is posterior mediastinum. Just follow the way it arches and curves around. Superior vena cava will also split into right and left brachiocephalic veins. This is different than the aorta. So your superior vena cava here will give a right brachiocephalic vein, let me use a different color, and a left. And then these brachiocephalic veins will eventually split into subclavian and internal jugular vein. Internal jugular vein, subclavian. Technically, these would be coming down because they're draining blood, but you get the point. This is different than the aorta. The aorta, it ascends from the heart, and then we said it arches, and then it descends. Off of the arch, you're going to get 3 branches. Only this one right here is brachiocephalic trunk. These 2 would be common carotid artery, left, because on the left side, and left subclavian artery. The right side starts as a brachiocephalic trunk, and then it becomes right subclavian artery and right common carotid artery. So that's a key difference between the superior vena cava and the aorta. Aorta only has 1 brachiocephalic trunk. So it doesn't start off with brachiocephalic trunk, and then they both split. Only the right side has a brachiocephalic trunk. The left 2 already are their branches. So no brachiocephalic trunk there. But the vein, you have a left and a right brachiocephalic vein. Okay, and we talk about the arch of the aorta, the branch of the arch, so brachiocephalic. You can use artery, you can also say just trunk, because technically it's the trunk that gives off the other arteries. This is like when we look at the abdomen, it's called celiac trunk, and then it'll give off 3 arteries like left gastric, splenic, and common hepatic, but whatever, that's for later. Okay, the other thing that is in the superior mediastinum are your vagus nerves. So you have a right and a left vagus nerve. The vagus nerve will enter anterior to the right subclavian artery. And then it gives something called a recurrent laryngeal nerve. The vagus nerve is going to come down, and then it's going to give off a branch that recurs, so goes back up. So it ascends. The right one ascends at the subclavian range, whereas the left vagus nerve will give off the left recurrent nerve around the arch of the aorta, which is lateral to the ligamentum arteriosum. This will definitely be a question. She will ask about either one of them, where they ascend. So the recurrent is the one going back up, ascending. So it can go to your larynx. Ligamentum arteriosum is a ligament between the arch of aorta and pulmonary trunk. So when you're a fetus, before your lungs are fully developed, you don't want blood to be going to your lungs because it's not going to do anything there. So this is your heart. Right atrium, right ventricle, left atrium, left ventricle. Aorta. And pulmonary trunk. Between your pulmonary trunk and your aorta, there is this thing called a ligamentum arteriosum. So arteriosum. When it says ligamentum arteriosum, this is in adults. In a fetus, it was called ductus arteriosus. It was literally a hole or a connection between the pulmonary artery and the aortic arch, so that when blood goes into the right atrium, down to the right ventricle, we don't want it to go to the lungs. So when it goes there through the pulmonary trunk, it actually skips through to the aorta so it can go to the rest of the body because the lungs aren't going to oxygenate it anyway. So that's what ligamentum arteriosum is. As you're an adult, so after you take your first breath, there's no need for that anymore. Your lungs start to work properly. So then this hole becomes a ligament, so it becomes closed. So it's a remnant of it. It's like what's left over of it. You also see a similar concept between, so I'm going to do this to tell you there's like a similar concept between the right atrium and left atrium. Same thing. If you don't want blood to go to your lungs, what would happen is usually blood goes right atrium, right ventricle, pulmonary trunk, oxygenated in blood, comes back, left atrium, left ventricle, through the aorta to the rest of the body. To skip that process, there was a hole between right atrium and left atrium, so that it could go straight here, down to left ventricle, and then to the rest of the body, because the lungs aren't working properly. So that is called, when you're a fetus, foramen ovale. Remember, foraмен's a hole. As an adult, it gets closed, and it's called fossa ovale or ovalis or whatever. So it's a similar concept in both cases. And then we also have a phrenic nerve that's in the superior mediastinum, and then your trachea is there, and your esophagus. Now, at the sternal angle, you will have a bunch of things that happen. So at sternal angle, so if you just looked behind the sternal angle, first thing is your trachea bifurcates. The next thing is that your aorta will change directions twice. So what that means is that your ascending will become the aortic arch, and then the aortic arch will become the descending. So let me show you what that looks like. So if this is the sternal angle, so this is your sternum. If this is the sternal angle, behind it, so ascending would be here, and then it becomes an arch, and at that same level behind, it descends. So only the aortic arch is above the sternal angle, which is what we said before, because these changes happen at the sternal angle. So aorta becomes arch, and then arch becomes descending. Wow, that's awful. This is descending. And then also your pulmonary trunk also bifurcates or splits into right and left pulmonary artery. There's only one right and one left pulmonary artery, which is different than veins. So for pulmonary, when we're talking about the arteries and veins that go to and from the heart and lungs, there's one artery on each side, so 2 total, which is different than the veins. There are 2 veins on each side, so 4 total. And this is all superior mediastinum. Some like location stuff. Thoracic duct is left side of the esophagus. And this makes sense because when we talk about like whole body lymphatic drainage, the thoracic duct will actually do 75% of the body. If we split the body into quadrants, so I'm like a stick figure guy, so he's happy. So if the body was like this quadrant, this quadrant, this quadrant, and this quadrant, these 3 will get thoracic duct. So everything from your upper left body, and the entire lower body, whether it's right or left, will go to thoracic duct. This top right is right lymphatic duct. So that gets 25% of your body. So it makes sense that the thoracic duct is more towards the left of the esophagus, because that's where it does most of its drainage. And then we said the trachea is anterior to the esophagus. The way I always remember it is it's more important to breathe than to eat. So the trachea should be anterior to the esophagus. Okay, is there anything else here? Oh, went over that. Oh, when we're talking about superior mediastinum, when it says contents, so anterior to posterior, we said the thymus, the thing that starts to kind of like not have any function as you're an adult. And then the veins, so like the superior vena cava and the brachiocephalic veins, arteries, the aortic arch. When we say airway, we mean trachea. And when we say alimentary tract, this just means the GI stuff. So in this area, we're talking about the esophagus. And that's everything superior mediastinum, so above the sternal angle. Now, lower, we have 3 different ones. Middle is the heart. It's as simple as that. Everything within the heart. Right atrium, right ventricle, left atrium, left ventricle, aortic or ascending aorta, pulmonary trunk. Everything that's within the heart in that range is going to be middle mediastinum. Anterior mediastinum is the smallest subdivision. So think about if you were looking at the space in front of the heart and behind your sternum, there is literally so little room. Nothing major can fit in there. So we're talking about like this purple range right here. Like nothing big is going to fit in here. So all you're going to have are like lymphatic stuff, like loose connective tissue, some ligaments, lymphatic stuff, few vessels. So like nothing really like notable compared to the other stuff. And then we have the posterior mediastinum. So now we're behind the heart. Also for middle mediastinum, you also have the phrenic nerve in here. And then you'll have some lymph nodes too, but those are like everywhere. But don't forget the phrenic nerve is also middle mediastinum, because that has to go down to the diaphragm. So it goes down through, so we saw it in the anterior, in the superior, not anterior. We saw it in the superior mediastinum. If it has to go down to the diaphragm, because C3, C4, C5 keeps the diaphragm alive, it has to go through at least one of these mediastinums in the inferior range, and it's actually the middle one that it goes through. And then posterior mediastinum. So now we're behind the heart, under the sternal angle, above the diaphragm, in front of the thoracic vertebra. So again, we are in the blue stuff. So under sternal angle level, behind the heart, above the diaphragm, in front of the thoracic vertebra. So in the posterior, these are all the stuff we just said. So superiorly, posteriorly, laterally, medially, whatever, anteriorly. Okay. So now, remember, we said after the aorta arches, it goes posterior and descends. So the artery here is the descending aorta. The vein is the azygous vein. Because remember, we said the azygous vein is posterior, and then it curves anteriorly to drain into the superior vena cava. Remember when we saw that in the impressions of the right lung. And then the nerves, you have your vagus nerve. Your splanchnic nerves are the ones that come off your sympathetic chain. You have a greater and lesser. These are like towards the back, like close to your vertebra. So it makes sense that they're in the posterior. You still have your esophagus there. You still have your thoracic duct, because remember, this goes through the diaphragm at T12 with the aorta. Because remember, it was I ate 10 eggs at noon. And then always you have some limbs going on. So we talked about all of these things. Azygous vein, we already said, arches over the superior aspect of the root to the right lung to join the SVC. So it goes over, curves around, and then joins the SVC. Then you have a bunch of things that drain into these azygous and SVC. So you have a hemiazygous and an accessory, which we'll see pictures of. And the nerve, which says splanchnic, so greater, lesser. There's also a least, so let me include that in here. Least wasn't on the lab stuff, so that's why I didn't put it here, but there is also a least. And then the esophagus, thoracic duct, largest lymphatic channel. We said 75% of drainage. Oh my god, I cannot write for shit. Okay, sorry for cussing. And then right lymphatic duct drains 25%. Specifically the right upper quadrant. This would do left upper quadrant, left lower quadrant, right lower quadrant. And then to remember the posterior mediastinum stuff, there's this mnemonic dates. So descending aorta, aka thoracic aorta. So you can also say like Tates. Shout out Tammy Curry. A, azygous vein. T, thoracic duct. E, esophagus. Then your splanchnics. And then middle mediastinum. So this is all the stuff we said for the heart. Okay, sorry. Phrenic nerve was included here. Shouldn't have done that to you, Paulino. So tracheal bifurcation happens behind the sternal angle. So here you can also get the left and right main bronchi. And then you have ascending aorta, pulmonary trunk, superior vena cava, all the stuff on the heart, cardiac plexus, blah, 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 whatever. Okay, recurrent laryngeal, we already talked about this, but this is a good image of it. So on the left side, vagus nerve comes down, but then you get a nerve that branches off of it and ascends. It recurs up. So left recurrent. This is at the arch of aorta, specifically lateral. Remember L. So lateral to ligamentum arteriosum. On the right side, it goes anterior to the subclavian. So this right here is the subclavian artery. And then same thing, it's going to ascend because it's recurrent. So it's going back up to hit your larynx. But here it happens at the subclavian artery. Whereas over there, it's around the aortic arch, lateral to ligamentum arteriosum. All this stuff says that. And all of this stuff says that as well. Okay. Now, pericardium. So 2 layers. You have a thicker layer and an inner layer. So between the two, it's called pericardial cavity. Cavity is just like an opening, so that's between them, and you have fluid in there. So 3 layers of heart muscle. You have epicardium, myocardium, endocardium. Think of this like here, like the left ventricular wall. That is myocardium. So the stuff on the outside would be epi, and the stuff on the inside, so within the walls, like the IV septum or something, would be endocardium, within the heart. So endo, myo, epi. Now, there's a space called the transverse cardial sinus, pericardial sinus. If you put your fingers behind the pulmonary trunk and aorta, but in front of the superior vena cava, you can like fit your fingers in there. That's a space in there. So you're going horizontal, so it's transverse pericardial within the heart sinus. So it would be behind the aorta and pulmonary artery, so those are in front, and then in front of the superior vena cava, so superior vena cava is behind. You can pass a finger through there. And then we'll go over oblique pericardial sinus when we're talking about the heart blood vessels. So blood supply to the pericardium, you get pericardiophrenik vessels. So pericardiac, so heart, phrenic going to diaphragm, but phrenic nerve is included in the middle mediastinum. And then you also have internal thoracic arteries and veins, which you saw in the lab stuff. The nerve supply, phrenic, which is for like pain. And then you also have some sympathetic stuff. So it's like your fight or flight that'll increase your heart rate, blood pressure, and all that stuff. Now, surfaces of the heart. You have an anterior surface, so this whole front thing. You have a right pulmonary surface, which is what we saw on the lungs and how that hits the lungs and the impressions it makes. Left pulmonary surface, and then a diaphragmatic surface. So diaphragmatic surface is going to be mostly left ventricle. So this, your diaphragm will sit like this. So it's mostly left ventricle, a little bit of right. Your right pulmonary surface, this thing that hits the lung is the right atrium. On the other side, it's the left ventricle for the left pulmonary surface. And then anterior, the most anterior is technically this right ventricle because this is like curved away, which is why you can't really see the left atrium. And then the borders, if you did each border, the border would be, so right atrium down up to the SVC, down to the IVC. Inferior border now would be mostly right ventricle and some left ventricle. Left border will be mostly left ventricle. Then you get some left atrium, so the auricle as well, which is the ear-looking thing in the left atrium. And then superior border is all the stuff on top. So you have your left atrium, right atrium, and these great vessels right here. So border is each part of the heart specifically. The surfaces are more just like flatter lines. Like what would hit this flat line here? What would hit this flat line mostly here? Which would be left ventricle specifically. And so on. Heart valves and where you can best auscultate them. Okay, so when you want to listen to someone's heart, this is where you listen to them. If you think about the way the heart is, your aorta is more to the right than your pulmonary trunk. Your tricuspid is more to the right than your bicuspid. Your top two are going to be aorta and pulmonary trunk. Your bottom two are going to be tricuspid and bicuspid or mitral. So the way I remember it is always play tennis matches. So this right here is going to be A or aortic valve, this red one. The blue is going to be pulmonary. Green is going to be tricuspid, and then purple is going to be mitral or bicuspid. So on the right side of this upper is where you listen to the aorta, versus left side for pulmonary, and then tricuspid and bicuspid are going to be, or mitral, are on the same side. So the actual locations, so aortic, fourth left intercostal cartilage, second right intercostal space is where you hear it best. So even though it projects that way, you hear it best at the second right intercostal space. Whereas pulmonary is going to be on the second left. They're at the same level here, except one is right of the sternum and one is left of the sternum. And then for the tricuspid and bicuspid, mitral is going to be a little bit lower, specifically at the apex of the heart, because that's where you hear that valve the most, which is the mitral valve. And then tricuspid is like more like, it's on the inferior side, but it's like in the middle of the sternum technically, so like right next to the sternum. So mitral will be like the farthest away from the sternum. And then, yeah, pretty much said everything. Okay, coronary circulation. So the blood supply around the heart. So we know the heart brings in blood from the top of the body through the superior vena cava, so everything above diaphragm. Everything below diaphragm will come to the heart through the inferior vena cava, goes to the heart, kind of like gets recycled because it goes to the lungs from the heart and then comes back to the heart oxygenated and then goes to the rest of the body. But the heart itself needs its own blood supply. So all of these things with the superior and inferior vena cava are blood coming into and out of the heart. Nothing about the blood that's actually supplying the heart and the valves and all the stuff that we need. So this is where the coronary arteries come into play. Now, this right here is your aorta. So what we did is we cut the aorta, supposed to be like this, pulmonary trunk supposed to be like this, but we cut them so we can see these vessels behind. The aorta, the arch of the aorta is the one that has the brachiocephalic trunk, left common carotid artery, and left subclavian artery. From the arch. From the actual ascending aorta itself, we get the coronary arteries. So, off the ascending aorta, we get a right coronary artery and a left coronary artery. And these are going to supply the actual, like, parts of the heart, the atria and all that stuff. So, right coronary artery coming right will give off a few branches. You'll have a marginal branch, and then it'll go to the back of the heart. So I'm going to follow it around up here. This will give you this posterior interventricular or posterior descending artery. Now, this artery is important. If this artery is coming from the right coronary artery, then the patient is right heart dominant. If posterior interventricular artery comes from right coronary artery. If it comes from circumflex, which is a branch of left coronary artery, then patient is left heart dominant. So that's an important artery, this back one. This posterior interventricular artery, so the reason it's called that is on the back we have left ventricle, right ventricle. Inter, between, ventricular, between the ventricles, artery. The way I know that this is the left ventricle and this is the right ventricle, whereas on the anterior side this is right ventricle and this is left ventricle, is because you have to know if you're looking at anterior or posterior. So when we're looking at anterior of the heart versus posterior, you can see, first of all, the apex is to the right, which is what we normally see because it hits the left lung. The other thing is you can see the pulmonary trunk and the aorta coming up. That's anterior. Posteriorly, you see the 4 pulmonary veins of the left atrium. So this is left atrium, so below it has to be left ventricle. Here you see inferior vena cava, superior vena cava. Those drain into your right atrium, RA. So below it has to be RV. Now, on the anterior side, between the ventricles, you have an artery and a vein that run together. Specifically, these ones right here. The artery, so anterior interventricular septum, or that area between them, between the ventricles. Along it, you have the artery, which is the LAD, left anterior descending. The vein is the great cardiac vein. On the posterior side, where am I going to write this? Let's do this. So posterior. Sorry for the handwriting. I'm trying to just not cover the mic so my voice doesn't go away when I'm talking. So I have to like angle the pen in a weird way. Interventricular septum. The artery there is posterior interventricular or descending artery. And the vein is the middle cardiac vein. So the way I remember it is this. If the heart is put anterior for you, you say great, thank you. So great cardiac vein. If they flip it, this thing's in the middle cardiac vein. Okay. Where are we? So right coronary comes from the aortic sinus, so from ascending aorta technically. The opening there is called the aortic sinus. So branches, so it also gives off an SA and AV nodal branch. Now, this differs in patients because the percentages are around like 60. So SA node, right coronary artery is about 60%. AV node is more likely. So obviously the other possibility is the left coronary artery could give it. But most of the time, 60% is even like most of the time, but majority of the time, SA and AV will come off of the right coronary artery. So they'll give you SA branch, AV branch. The right marginal branch that we saw goes down immediately when we were looking at this right here. And then posterior interventricular artery, this determines heart dominance. And then you'll also have branches that go to the actual interventricular septum. And it'll supply part of the diaphragmatic surface. Now, the left coronary artery on the other side gives you first a diagonal branch. Actually, first it'll give you the LAD, which is... Okay, so it says a branch of the anterior interventricular branch. So the key artery here is LAD. So you'll have, this is your heart, off the aorta. We already did right coronary artery, so left coronary artery will give you an LAD, and then something diagonal off of it would be your diagonal branch. Just like before, you also have a marginal branch on the other side coming down, and then the one that goes to the back is circumflex. So this is the one that sometimes, and this other one going down is marginal. It's like the one on the right where the marginal goes down like this. So this is the one where it could possibly give you the posterior descending, which would make you left heart dominant. And this determines coronary dependence. And then some people have a third coronary artery, a posterior one. So not just right and left, but also posterior. But that's more rare, it's just 4%. And then we already talked about coronary artery dominance. So blood supply to the AV and SA node, we already said. Most of the time it's from the right coronary artery, but not always. And then based on where the arteries are going, you can kind of see what they supply. So the right coronary artery is going to do right atrium, most of right ventricle, part of left ventricle, because technically it does the septum as well, so it'll hit left ventricle a little bit. So the diaphragmatic surface, so this is the bottom part, which makes sense because it's hitting the septum. And then we said SA and AV node in 16-80%. So on the left side, we'll do the other stuff. So it'll do left atrium, most of left ventricle, part of right ventricle, because it'll also do like some of the septum. And sometimes it can go to the back and supply the interventricular on the back to determine heart dominance. So in both cases, it could hit right ventricle. And then most of the interventricular septum is key, because this one has the LAD, or left anterior descending artery, which is this thing right here. So it'll do most, about 2/3. And then in some cases you get SA or AV. Okay, now the drainage. So these are the right and left coronary artery take blood to all these branches of the heart. But now we got to recycle this blood, so we need the blood to come back to the heart. So it comes back through this thing called a coronary sinus. This is the coronary sinus. It is behind the heart, because we know this is left atrium, this is left ventricle, right atrium, right ventricle. And you can see all of these veins that drain into it. So we already saw this middle cardiac vein. It runs with the posterior interventricular artery. This is the oblique vein that I was talking about earlier, which oblique plus the cardiac vein, which is coming from the front and going around to the back, those together will form your coronary sinus. So it's technically oblique plus great cardiac vein. Oblique vein is like a remnant of the superior vena cava, which I believe is in the notes here. And then all these things will drain into the coronary sinus. So small cardiac vein will drain here, middle will drain here, this will drain here, this will drain here, and then all of these will then go into the right atrium to this thing called an opening to coronary, or opening of coronary sinus, to bring it back to the heart, to the right atrium. I mean, it's still within the heart, but bring it back to the right atrium, so it can go right ventricle, to the pulmonary trunk, come back to left atrium, left ventricle, and then when it goes back up to the aorta, that's when it goes through the coronary arteries. So coronary arteries take blood to the parts of the heart, coronary sinus will drain it back. So to summarize, coronary sinus, the big blue thing in the middle, formed by the union of oblique and great. You can see that on the side. It's posteriorly in the coronary sulcus. The sulcus is just like the opening, or like the divot inside that it sits in. So what it sits in is the sulcus. The actual thing is the sinus. Then it receives great cardiac, blah, 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 whatever, all this stuff. We already said great cardiac travels with anterior descending, middle with posterior descending. She could definitely ask this stuff. And then oblique vein we just said is a remnant of the SVC. Now, anterior cardiac vein so let me see if there's a good picture of these. So if you can see these things right here, these anterior cardiac veins, if you look at their location, so these are different than the small in the middle and the great. These go right into the right atrium, which is unique, because all of the other stuff we talked about drains into the coronary sinus. So the great cardiac, middle, small, oblique, all this stuff, they drain into the coronary sinus, which then drains the right atrium. Whereas these have immediate access to the right atrium. So that's something she could also ask as well, is that they drain directly into the right atrium. So not coronary sinus first. Okay, and then the heart. So 4 chambers of the heart, 4 valves. 2 semilunar, which are your aorta and pulmonary valves, and then 2 AV, atrioventricular. So between your right atrium and right ventricle is your tricuspid. Between your left atrium, left ventricle is mitral or bicuspid. Aorta and pulmonary are called semilunar because they're literally shaped like half moon, so semilunar. And then we talked about from inside to outside, you have endocardium, myocardium, pericardium. So, inside of your right atrium, we have holes, we have muscles, we have a bunch of stuff. Sinus venereum, vein. So, it's a posterior wall where you can get the vena cava stuff, superior and inferior vena cava, and the coronary sinus. Coronary sinus is just a big vein, so makes sense. Sinus venereum has your veins, the holes that bring blood back to the heart, SVC and IVC from the rest of the body, and the coronary sinus from the heart. Pectinate muscles. These are pectinate muscles. They come from something called a crista terminalis. So, pectinate muscles, crista terminalis. Right AV orifice, atrioventricular. So now we're talking about the actual tricuspid valve, connecting the right atrium to right ventricle. Fossa ovalis. This is the thing we talked about earlier, where it used to be foramen ovale as a fetus, but then it closed up. Now it kind of looks like a thumbprint. And this is between right atrium and left atrium. So you can see on the right atrium, it goes through. This is the same thing. This is just fossa ovalis. And then coronary sinus, which we know is what drains in there. We already saw it over here to the right atrium. So there are 4 openings in the right atrium. Technically used to be 5. So superior vena cava, inferior vena cava, the opening to the coronary sinus, which you can't see here, the valve going from right atrium to right ventricle, and then there used to be the foramen ovale, now there isn't. So it used to be 5 openings, now there's only 4. Now, right ventricle, so now we're lower. You have the tricuspid valve. Conus arteriosus is the thing that leads to the pulmonary trunk, because blood has to go from right ventricle to the pulmonary trunk. So the conus arteriosus is sort of like the pathway that leads it to the pulmonary trunk. The supraventricular crest is what separates the right ventricle part from the pulmonary trunk part. So separates the conus arteriosus, which is the right ventricle part, from the outflow, which is the pulmonary trunk part. And then moderator band, so this is important. It's unique. Unique to right ventricle. So not in LV. This is like the lab stuff, but to kind of skim over it, this is your tricuspid valve. This whole thing right here. So you have 3 leaflets, 1, 2, 3. These cords that come down are your chordae tendineae, and they connect to papillary muscles. So there's 3 valves, or 3 cusps, going to 3 papillary muscles. In the left ventricle, these papillary muscles will connect to the wall. Nothing else connects them. But in the right ventricle, you have this key thing called a moderator band. So this connects the papillary muscles to the wall. So it's like a middleman. It moderates this. So this is only in the right ventricle, not in the left. And then you have the IV septum, which is, so right ventricle, left ventricle, between IV septum, interventricular. between ventricles and septum. Now left atrium. So left atrium is what's bringing blood back from the lungs. So when we're talking about the heart, only within the heart, arteries away from heart. So the aorta brings blood away from the heart. Pulmonary artery brings blood away from the heart. So veins would bring them back. So the oxygenated blood from the pulmonary veins is coming back to the heart, to the left atrium. And remember, there are 4 pulmonary veins, 2 on each side. So 2 right, 2 left, which is different than pulmonary arteries, which is 1 right and 1 left. So 2 total. So this is going to be similar. So atrium, intra-atrial septum. Sometimes I can give to the, where is it? Did we talk about the AV stuff? We did. So there's an AV orifice. Let me see if I can find a picture of that. I don't think it's on here. And then it's thicker than that of the right atrium. And that also applies to the ventricles as well. So LV is also much thicker than RV. Even the papillary muscles are much bigger, thicker, even though there are 2 because it's bicuspid compared to 3 on the other side. So there are only 2 cusps and papillary muscles. They're thicker because they have to deal with sending blood to the entire body through the aorta. So left ventricle, thicker walls, cavity is longer than that of right ventricle. And then you have an atrioventricular valve and a semilunar valve. So atrioventricular, bringing blood from left atrium to left ventricle, and then here it's taking blood from left ventricle to aorta. Oh, this is just the bicuspid. That's what I was trying to look for. This is just the bicuspid valve, which is this thing right here. So orifice is just like opening. So left AV, opening, atrioventricular. Okay. And then we kind of talked about all this, but tricuspid valve, you have 3 papillary muscles that are going to lead to 3 leaflets that go to 3 papillary muscles. So each leaflet, so 3 total, go to 3 papillary muscles. But on the right side, you have the moderator band that connects the papillary muscles, or connects papillary muscles to wall. But the actual valve itself is just 3 leaflets. And then mitral is going to be 2 and 2. And then they each have chordae tendineae and all that stuff. Semilunars, we're talking about aortic and pulmonary. We kind of already talked about this, where they go from to where. So you can kind of skim over these. And then if you look at the, where is it? Oh yeah, so the nodes. So you have an SA node, which is higher than the AV node. The way I remember it is this is just sinoatrial. So SA, atrium is up higher, but AV is atrioventricular. So between atria and ventricle has to be lower. So SA first, which is the natural pacemaker. No L, so pacemaker. And then AV node is next. And then they go through this bundle of His. And then you get the left and right bundle branches. And then you get the Purkinje that emerge from the bundle branches. So all of these things would be Purkinje fibers going to each side. So SA node triggers an electric impulse, setting the rhythm 60 to 100 times per minute. This is actually what a normal heart rate is. 60 to 100. This is different than blood pressure. Blood pressure is the one that's like 120 over 80. This is your systolic, and this is diastolic. But this is actually heart rate. And then there's a delay. So you could probably ask this. This was like a physio thing though. There's a delay to allow the atria to empty completely. So atrial contraction will fill the ventricles, and then you get the delay in the AV node. And then ventricular contraction. So when the atria contracts, so right atrium is pushing blood through the tricuspid into the right ventricle. This is diastole. Blood is staying within the heart here. It's filling up the ventricle so that it could push it out of the heart in systole. So atrial contraction, we're filling the ventricles. But when the ventricle contracts, now it's either going through the pulmonary trunk, or from the left ventricle, it goes through the aorta. And that's systole. That's blood leaving the heart and going to the body through the aorta. All right. That was all the heart stuff. We have like 16-ish pages left, so let's go through abdomen stuff. So abdominal quadrants. There's like an easy way to split them up, where it's just right upper, right lower, left lower. But she did say to know these ones. So the way I remember it is for the sides, it's HLI. So right hypochondriac, right lumbar, right iliac. Left would be the same, HLI. And then belly button's in the middle, so that's your umbilicus. Above, epigastric. Below, lower, hypogastric. So those are the 9 quadrants. So for example, like your liver would be mostly in here, but it'll also have some in here and a tiny bit in here and so on. So that's how you can tell. So if she tells you like which of these quadrants is the liver not located in, and she has this and this and this and this, and then she has this, you know it's not in the left iliac because that's low left. So those are the different quadrants. They're separated by 2 sagittal or vertical lines and 2 transverse or horizontal. That creates your tic-tac-toe. So like if someone starts middle, and you tie it. Sorry, I'm exhausted. Okay, so whatever. Okay, we just did this. Okay, so now these are some key things. So in the right upper quadrant, you will get the liver, specifically the right lobe. The gallbladder sits there with the liver, so gallbladder has to be there as well. Look at this stomach right here. Everything for the stomach except this end part is in the left upper quadrant. But this end part right here is called a pylorus. This green thing, by the way, is your gallbladder. And then this big red organ is your liver. So the pylorus of the stomach is right upper quadrant, but everything else for the stomach, so excluding pylorus, is left upper quadrant. Okay, pancreas does a similar thing. So the pancreas head would be here, but then the body and tail would be in the left because the tail goes towards the spleen. So pancreas, the head would be there, but the body and tail go there. This is one of those things where I was saying, like, especially for the GI stuff, know the lab stuff first, because all of this will start to make sense. Now, some of these are like easier, like, okay, right kidney, right versus upper, or right versus left, ascending colon versus descending colon, but only the superior part, because ascending colon will have an inferior and a superior part. They're both on the right side, but one's upper, one's lower. Then transverse, descending, sigmoid, rectum, and whatever. So, transverse colon left half will be left upper, so this right here, whereas the right half would be right upper. colic flexure and splenic flexure just mean this. So you have an ascending colon, transverse colon, and descending colon in your intestines. Where your ascending becomes transverse, there's this flexure right here called hepatic or right colic flexure. The right side is the liver side. That's why it's called hepatic. So on the left side, the big organ here is spleen. So this would be splenic flexure, which separates transverse, which is still transverse, from descending, or left colic. And then what else? And then if your kidney is going to be on one side, your suprarenal gland just above your kidney is also going to be the same thing. So same thing here and here. Now when we get to the lower stuff, so before your ascending colon, you have your cecum, and off of it is your appendix. So we're talking about this area. So those have to be right lower. Your small intestines go duodenum, jejunum, and then ileum. Ileum is mostly in the bottom right. So most of ileum. Ascending colon, we just said the inferior part. And then you have all of this like lower stuff. So ovarouterine tube, ureter, spermatic going through the superficial ring, uterus, if it's enlarged, bladder. All this stuff is going to be the same on either side. So on the left side, you have your sigmoid and you have your descending colon. So if you know the lab stuff, this should make a lot of sense. So definitely don't sit and memorize these. That's like 50 terms or whatever. Just understand the lab stuff and the order they go in. So to kind of summarize, food will come through the stomach, go through the C-shaped duodenum. Then you have the small intestines, all of them. So you have jejunum, and then more on this side is ileum. And then large intestine starts with cecum. You have an appendix coming off of it, which is not important. Ascending colon, transverse colon, descending colon, sigmoid is like S-shaped, and then it leads into your rectum. So if you know this picture, then you can see everything is. And then the higher organs, you have your, we said stomach's there. Also your liver would be around here. Spleen would be around here. Pancreas would be posterior to your stomach. And yeah, okay. Layers of the anterior and anterolateral abdominal wall. So last exam, she had something where she was like, if you poke this, whatever, what layers do you go through and all that stuff. So I tried to come up with an acronym. I hope this helps. But it's super cars scare dads, especially if they're fast and extra powerful. If this doesn't help, I'm sorry, but I tried. So first you have your so superficial fascia. Then you have a fatty superficial fascia, but specifically called campers. So CA, cars. Then you have a deeper one, but it's called scarpas, so scare. Then there's the deep fascia. So this is superficial, this is deep. These are like fatty superficial, deeper membranous or whatever. So that's why they have different names. So deep is going to be the dads. And then these three are important because that's what differs or differentiates your anterolateral abdominal wall from your anterior abdominal wall. So imagine this is like your stomach or whatever. This is anterior. This is like anterolateral. In here you have your like six-pack muscles, which is called your rectus abdominis. So that's going to be anterior. But lateral, you have the muscles that either run like this, which is external, or like this, which is internal, or like this, which is transverse. So that's where the especially if there comes from. External, internal, and transverse muscles. Then you have, so I put the and here because the and goes hand in hand with the word above. So this is fast, so fascia, but specifically transversalis, so the and means bring down this T. And then extra and powerful are the same, so they kind of get the and too, because it's extra peritoneal fat, and then P is parietal peritoneum. So I don't know if this helps. I hope it does. But that's how you go from most superficial to deep. So the most superficial would be this. The deepest would be the actual parietal peritoneum, which is the most like outside. Or sorry, most deep. Anterior, the same exact thing. This, everything is the same. The only difference is these muscles right here. This one's way easier to remember because the key thing is the rectus abdominis. In front of it, because we're going superficial to deep, is going to be anterior rectus sheath. Behind it, posterior is going to be posterior rectus sheath. So as long as you remember rectus abdominis, you remember it's your six packs or your six packs in the middle. You don't have your six pack off to the sides, unless you're doing some like crazy shit, or you got some new routine or some shit. I don't know. Okay. Linea alba is just like the line in the middle. So if this is your stomach, the line that literally goes up like this is your linea alba. Then you have two lines that kind of come up around like this. And these are called your semilunaris lines, or linea semilunaris, or whatever it is. Okay. Peritoneum. So thin serous membrane that lines the abdomen and pelvis. It's deep to the fascia of the abdominal cavity. Then it lines the abdominal cavity, so like the parietal pleura, visceral pleura. Between the visceral and parietal pleuras contains fluid. Okay, remember, parietal peritoneum is the one that feels pain, we said. This is important. Visceral does not feel pain. If something is wrapped by peritoneum all around, front, back, top, bottom, all that stuff, it's intraperitoneum, covered by peritoneum fully. If something is retroperitoneal, it's behind. Retro means behind. If someone has retrograde amnesia, they forget things that happened in the past behind them. They have no problem with stuff in the future. So retroperitoneal, behind peritoneum. So anterior is covered by peritoneum. Only the anterior, not posterior, because it's behind it. So only on the anterior surface. Secondary peritoneal is usually when something is not fully intraperitoneal. So most of it, or parts of it, are intraperitoneal, but some are not. And an example of this is the pancreas. The pancreas is not all intraperitoneal. And then subperitoneal means under. So top is covered by peritoneum, not bottom. So pancreas, for example, when we said secondary retroperitoneal, it's because most of it is retroperitoneal, but the tail is intraperitoneal. The tail is the one that goes to the spleen. Tail of pancreas goes to spleen. So that's intra. So it's not fully retro, but it's secondary retro because it has an intra part. This can happen sometimes if like an organ has multiple parts. And these are examples of all of these. So stomach, intraperitoneal. Aorta, retroperitoneal. Pancreas, secondary. and then uterus is subperitoneal. Also bladder is another example. Bladder, also subperitoneal. For the uterus, it's specifically the cervix that's subperitoneal. That's why I put cervix sub. Okay, now there's also a bunch of stuff that we see in the gut, and that's where like neurovascular stuff will travel between the parietal and visceral layers, and this is where we get into the like omentum and mesentery and stuff. So, peritoneal ligament, double layer. That's important. So it's a double layer of peritoneum that connects an organ with another organ, or an organ to the abdominal wall. So, mesentery would connect organ to the abdominal wall. The greater omentum and lesser omentum connects organ with another organ. So omentum, for example. Omentum, double layered, passes from the stomach and duodenum and connects it to adjacent organs. So organs to organs, omentum. Organ to posterior wall, mesentery. Like, this is very important to differentiate. So, your stomach has a greater curvature, because it's this whole thing, and then a lesser curvature, this thing. The nice thing about these is that the omentum follow them. So, greater curvature, you get the greater omentum. Lesser curvature, you get the lesser omentum. So, lesser curvature would be going from stomach and duodenum to, so if it's going to connect something going this direction, it has to be an organ in that direction, which is your liver, because that's the right side of your body. So, hepato, liver to stomach, gastric. So this right here, I'm going to say HG, would be this one, HG. Hepatoduodenal, liver to duodenum, liver to stomach. That's your lesser omentum. So greater omentum will be going the other direction. So it'll be just connecting the stomach to things over here. And there's a bunch of stuff in those other directions that we'll see. It literally hangs like an apron. And the key thing here is it connects to the transverse colon. Because transverse colon will be below the stomach, right? Because you have your transverse colon here, descending, ascending, and all this stuff, whatever. So the key thing is it connects to the transverse colon. Mesentery, we said, connects organ to posterior abdominal wall. Mesentery proper, this is the one we usually see, especially in lab. It's the one that's on the small intestines, specifically the jejunum and ileum. Jejunum and ileum. You also have one on like your transverse colon, sigmoid colon, and appendix. But this is different than the curvatures, because the curvatures would be connecting the transverse colon to the stomach. This is connecting transverse colon to posterior abdominal wall. So, like, make sure you know the difference. Mesentery connects to posterior abdominal wall. Omentum connects organ to organ. So it's connecting the transverse colon. It's not connecting it to the posterior abdominal wall. It's connecting it to the stomach. And then peritoneal folds. These are the umbilical folds we talked about. Remember, like, if you removed like the front wall of your abdomen, you would have a fold like this, 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 and this. This one right here is the median fold, which gives rise to your urachus, which is like a remnant where when you aren't a fetus anymore, you don't really use. So it has to do like fetal stuff. So this is medial. So medial, not median fold. And this is your umbilical artery. So you'll get the same thing on this side. That's a branch of your internal iliac, which we saw. And this one right here is your lateral fold, which gives rise to your inferior epigastric vessels. And this is also lateral here. So lateral, medial. So you have a right and left. So this technically would be left, left, right, right. There's only one median, but there's two medials. And then you have some spaces within, like, the abdomen. So there's a greater sac and a lesser sac. They communicate through something called an omental foramen, or foramen of Winslow, which we'll see in a little. So greater sac is across the entire abdomen, and then diaphragm to the pelvic floor. So it's like the whole thing, and gives you a bunch of recesses or free spaces. Like when you had recess in school, you had like a free time to do whatever you wanted, free space. So subphrenic, remember phrenic is diaphragm. So under diaphragm, also called suprahepatic, so above liver. So the space between the diaphragm and the liver. Hepatorenal, space between liver and kidney. It's called Morrison's pouch. Paracolic, remember we said para means next to, so next to your colon or large intestine. So if this is ascending, transverse, descending, the space here between the colon and the wall of your body is the paracolic space. Lesser sac is an irregular space. This is behind the liver. Behind the lesser omentum, which is the thing that's coming off the lesser curvature of the stomach, behind the stomach and the upper anterior part of the greater omentum. So it's closed, but it can communicate with the greater sac through the epiploic foramen. So if you put your hand like behind the stomach, there's a hole called the epiploic foramen. This is where the greater and lesser sac communicate. And then we just said all the stuff: omentum, epiploic foramen, greater wrist, lesser sac. This shows you like a picture of it. Lesser sac's like the blue thing. You can kind of just like skim over the stuff again. Same thing here. Pouch of Douglas, this is the thing we saw last exam, but you have a bladder, uterus, rectum. Between uterus and rectum, you have a recto-uterine pouch. If there's fluid there and you want to drain it, you go through this posterior fornix right there. To drain it. Okay, portal triad and where it's located. So, portal triad. You have hepatic artery, hepatic portal vein, bile duct. Your bile duct is when you're cystic. So when we say cystic, from gallbladder, duct joins your common hepatic duct. The reason it's called common is because it had a right and a left hepatic duct. They came together to form the common. When these go together, they form your bile duct. This is also called common bile duct. Cystic duct. This thing from the gallbladder joining your common hepatic duct. So these will be right and left. Forms your bile duct. Your bile duct will go deep and it'll drain into the major duodenal papilla. This is important. Eventually, your pancreatic duct will also join the bile duct. So joins bile duct and drains also into this. It's like a little hole opening. You have something called a minor duodenal papilla. And what drains in there is the accessory pancreatic duct. So the way I remember it is the pancreatic, the main thing is going to be the major. So your main outfit is your major thing. Accessories are a minor part of your outfit. So that's kind of like how everything drains from gallbladder and liver into the duodenum and then so on. So your portal vein, we said, where's this? So carries blood and bile into and out of the liver, providing hepatic cells with oxygen. Located in the duodenal ligament. Oh, this is important. So the portal triad is located in the hepatoduodenal ligament. So you remember when we were talking about the lesser omentum like 2 minutes ago? Where is it? I feel like I'm blind. Okay, omentum, lesser omentum. There it is. Hepatoduodenal ligament. So the thing that connects your liver to your duodenum, within that, so portal triad is within this. So literally within here, your portal triad runs. Your portal triad is the three main things for the liver. So it's the portal vein, so hepatic portal vein, hepatic artery, and bile duct. Those are within the hepatoduodenal ligament, which is part of lesser omentum. And then blood and bile is being carried. Okay, I think that's good for that one. Now, superficial and deep inguinal ring. So, your main difference here is this thing called Hasselbalch's triangle. Where is it? Hasselbalch. Okay, this thing. So Hasselbalch's triangle is an important landmark for the differences between, so really here it's the difference between difference between direct and indirect hernias. So the way it works is this is your inguinal ligament. This right here is your superficial inguinal ring. The farther one is your deep inguinal ring. So it goes from your ACES, anterior superior iliac spine, to your pubic tubercle. Structures are going to exit and enter through this, but sometimes you can create complications that cause herniation. So there are two openings, lower abdominal wall. The way it's formed is we have external oblique muscles. Remember the ones that it's like hands in your pocket? So they will actually wrap back around to create this ligament. So it's like if your fingers were like grasping something. So they go in a certain direction, they like grasp it. And that's how they're shaped. Transverse spermatic cord. The key thing about this is that in men, the spermatic cord goes through this, but in women, it's the round ligament. And then in both cases, it's ilioinguinal. This is the key difference here. And okay, those just add some information. So we said this is in both, and then you get like blood and lymphatics, whatever. We just talked about this. So it's the folded lower border of the external oblique. That's what creates that's what forms the inguinal ligament. It's called Poupart's ligament. Beautiful name. From the floor to the inguinal canal, blah, 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 whatever. Okay, so Hasselbalch's triangle. If you have a herniation within Hasselbeck's triangle, it's direct. So relate direct and indirect to Hasselbeck's triangle. If it's not within it, then it's indirect. So this is how you classify the inguinal hernias, cornerstone for repair of hernias, anatomical landmark. So the way it is medially is your rectus abdominis muscles. These are your six packs, your abs. Laterally is your inferior epigastric vessels. Remember we said these come from the lateral fold when we were doing the medial and lateral umbilicus, urachus, umbilicus, and inferior epigastric vessels. This is actually a branch off of your external iliac artery. I don't know if she needs us to know that. But, and then this right here is your inferior B inguinal canal. So these are the borders of it. So it's a weak, prone area to direct inguinal hernias. This is very important. Direct. It's weak, causes direct, not indirect. So hernias, things can like either go through or get stuck and all that stuff. Usually an example of this is like a patency of a process vaginalis. It doesn't go through all the way when you're developing. So in young males, this actually causes cryptocortism or cryptorchidism. So cryptorchidism, which is undescended testes. So it won't go all the way down, so it actually like gets stuck higher up. Okay. That's indirect. This is usually like a birth thing, or it's a congenital thing. So indirect is the cryptorchidism one. The direct is the one that's through the Hasselbeck's triangle. So this is not through the triangle because it's indirect. Remember, relate direct and indirect to Hasselbeck's triangle. So this, for something like this, something could just go through the wall in the triangle, and usually this is like older people. So if she gives you something, it's a young male, undescended testes, most likely an indirect hernia due to congenital anomaly. If it's over 40 and then he had some hernia, all that stuff, it's like when old people think they can still play soccer and they go to play soccer and they shoot a ball and now they can't feel their groin or whatever and they're injured. That's a direct hernia. Okay, now the layers of the abdomen. She has a good picture of this in her PowerPoint. I'll send it in the GroupMe because it shows all the different colors and what things stay the same, what things don't stay the same, how they change and all that stuff. So I'm gonna star this and I'm gonna put send pic in GroupMe, but it's literally just a picture from her. It's the picture from her PowerPoint where it had a bunch of colors and it was like, if when this goes down, it changes. So for example, when the skin goes from anterior abdominal wall to the scrotum, it's still skin, but in the spermatic cord, it's scrotum. Your subcutaneous tissue changes a little bit from like fatty to dartos fascia and whatever in the muscle, but it does not go down all the way. Your external oblique is in your abdominal wall. It's not going to be in your scrotum. Now it's external spermatic fascia. In your spermatic cord stays spermatic fascia. Your internal oblique, these are oblique muscles. So external, internal, and transversus have no business going into the scrotum. So your internal becomes your cremaster, external spermatic, and the transversus doesn't do anything. So transversus ends in the abdomen. So if she asks you, where does the transversus abdominis muscle end? In the abdomen. The fascia also ends there, but it becomes the internal spermatic fascia. So external oblique muscle becomes your external spermatic fascia. transversalis fascia becomes your internal oblique. And then peritoneum just gets different names each time. So in the spermatic cord, it's tunica vaginalis, then it's the vestige of the process vaginalis. Okay, now, which arteries are at risk for bleeding from gastric and duodenal ulcers? So both gastric and duodenal are called peptic ulcers. So they develop in the digestive tract, primarily caused by H. pylori bacteria NSAIDs. I don't think we have to know why NSAIDs cause it, but pretty much like NSAIDs can cause stomach ulcers because they inhibit something called COX-1. I don't think she'll go into details of this, but COX-1 inhibitor. And what happens is when you reduce COX-1, you reduce the prostaglandins, and those protect like your stomach lining, and without them, then the barrier breaks down, so you get all this stuff. Like you can get ulcers, you can get bleeding, and all that stuff. Peptic ulcers, bleeding is usually due to the gastroduodenal and the left gastric. So if we're saying there's something that's going to hit the stomach and something that's going to hit the duodenum, cause these ulcers, then the gastroduodenal one has to be the duodenum one, because all the one's just left gastric, which is for the gastric. Left gastric artery is one of the branches of the celiac trunk. Your celiac trunk branches are left gastric, which goes to stomach, splenic, which goes to spleen, and common hepatic, which goes to your liver. Gastroduodenal is a branch of common hepatic artery, which is a branch of the celiac trunk. So posterior duodenal ulcers are going to be caused by the gastroduodenal artery, most frequent source of bleeding, located behind the duodenal bulb, and there are other sources, whatever, other potential sources. The reason the other potential sources include branches of the superior mesenteric artery is because if you remember from the embryo stuff, for the duodenum, the top half is supplied by celiac, because that's foregut. And then the bottom half is supplied by the superior mesenteric artery, because that's midgut. So we know the main cause is the gastroduodenal, which comes from common hepatic, which is a branch of celiac. But that's mostly for superior. The inferior can also have a problem if it's a superior mesenteric artery cause. And then with gastric, these are from the left gastric artery along the lesser curvature of the right gastric artery. So left gastric comes from celiac trunk as well. And then we said NSAIDs cause it. So what organs do the following arteries supply? Celiac, trunk, SMA, IMA. So we already said celiac's your foregut. So this is like all the endo stuff, or the embryo stuff before. So left gastric, splenic, and common hepatic we just said. So SMA would do midgut. So when you get lower, you go pancreas. Then you go duodenum, lower part. Remember, we said lower duodenum. This is duodenum. After duodenum, you get the other small intestine stone, jejunum, then ileum, then cecum. Appendix is there, ascending colon, and then 2/3 of the transverse, which leaves the IMA with the rest of the transverse, and the descending colon, and the sigmoid, and the superior part of the rectum. So the thing that I drew out earlier, with the way everything goes in order, like if you just break them down into thirds, that's how it is. So liver, let me draw this out in colors. So let's do celiac, let's do blue. SMA, let's do red. And then IMA, let's do purple. So liver, stomach, spleen is all celiac. Part of the duodenum, so I'm going to do this part, is also celiac. Now SMA gets the other part of the duodenum. It also gets the pancreas behind the stomach. It gets the jejunum. It gets the ileum, which is all like your small intestine stuff. It gets the cecum. It gets the appendix. It gets the ascending colon. It gets the 2/3 of transverse colon. But then the IMA will get the remaining of the transverse colon, descending colon, sigmoid, and then rectum. So hopefully that kind of makes sense. But yeah, it goes foregut, midgut, and hindgut. And they kind of go in order. And then some of like the actual artery names. I mean, if you just think about it, it makes sense, right? So like pancreatico-duodenal, jejunal, ileum, ileocolic. Colic is ileo is ileum, which is small intestine. Colic is for large intestine. So technically that's the first part. It's called ileocecum as well. That's the connection between small intestine and large intestine. So right colic would be for ascending colon. And the middle colic would be transverse colon. Whatever, left colon would be descending. Sigmoid for sigmoid. Superior rectal from IMA. Middle rectal, remember, not middle rectal, because that's a branch of internal pudendal off internal. Oh yeah, this was last exam stuff. And then the key thing here with the drainage is, so behind the neck, this is important, behind the neck of the pancreas. So this is your pancreas. This is the head, body, tail. The tail goes to the spleen. Because remember, only the tail is intraperitoneal, we said. Everything else is retroperitoneal. So behind peritoneum. Behind the neck, so this is the neck of the pancreas right here. If this is the head, that's the neck. Behind the neck, you have your hepatic portal vein. Your superior mesenteric artery, so usually with stuff that's on the right side, they'll drain straight into it. So your superior mesenteric artery will drain straight into this, whereas your inferior mesenteric artery will drain into your, vein, not arteries. I'm talking about veins. So superior mesenteric vein will drain into your hepatic portal vein directly. Now you have a splenic vein that goes here. So splenic plus superior mesenteric vein equals hepatic portal vein. Your inferior mesenteric vein does not go into the hepatic portal vein. It instead drains into this. And the reason for that is your aorta is in the middle, your IVC is on the right, your inferior vena cava. So things on the right can drain quickly into it or directly, but things on the left have to go through something else. We also saw that with the gonadal veins. So this is just to like, not to confuse you, but right gonadal, so either testicular or ovarian, depending on the gender, goes directly into IVC, inferior vena cava, whereas left gonadal goes to left renal, which then goes to IVC. So this is a similar concept, but here they're going to the hepatic portal vein, which will do their thing in the liver, and then through hepatic veins will go to the IVC. I don't want you to be too messy. So if you know the arteries, all this stuff should make sense as well. Then spleen location, we know it's on the left side, left upper quadrant, left hypochondric. If you're using like the 9 things, left hypochondrium, if you're using the 9 things instead of the 4 things to split the regions of the abdomen. There's a gastrosplenic, so stomach to spleen, and leno-renal, spleen, kidney. And that's what has the splenic artery, vein, and tail of pancreas. So this is important, because if you're trying to remove the spleen, so if you remove someone's spleen, need to cut off blood supply, so remove this artery. So it would be within this ligament. So that's important. So other things could get damaged as well, like maybe the tail of the pancreas or something in the kidney. So we already said this and this. Spleen sits on the phrenocholic ligament. So the reason this makes sense is you have diaphragm, spleen, and then you have your intestines, right? So if there's a ligament that connects your diaphragm, phrenic goes to diaphragm, to colic, large intestine, makes sense that the spleen sits on top of it. Blood supply and lymphatics. So the artery, we already talked about the splenic artery. Vein is a splenic vein, and then it drains to the pancreatico-splenic nodes. So spleen to pancreas, and then remember pancreas has its own duct that goes all the way to the major duodenal papilla, like we said before. So pancreas, relationship to the duodenum. I believe this is the last section. It is, okay. So elongated gland located behind the stomach. So remember, stomach is anterior to pancreas. You knew what your stomach was way before you knew what your pancreas was, or at least I hope. So stomach comes first. So it's nested in the C-shaped curved duodenum. There was a pancreas in lab that was like this, showed the head and everything. But then you get this C-shaped thing. Do not confuse this with the head of the pancreas. This is the duodenum. This is the head of pancreas. They also showed this portal vein coming out behind it, because remember, it's behind the neck of the pancreas. So don't confuse the head of the pancreas with the C-shaped duodenum. Body and tail go towards the spleen. Body, tail, spleen. It's retroperitoneal, except tail, which is intraperitoneal. So endocrine functions, hormones will be insulin and glucagon for the pancreas, but exocrine is like digestive stuff. So overlying bodies of L1 and L2 for location stuff. Posterior stomach, duodenum obviously is on the right side. Spleen is going to be on the left side. Transverse mesocolon is going to be to its anterior part, because this is behind the stomach. Right under is going to be mesocolon. Your transverse colon. What else? We already said the head of pancreas by the C-shaped duodenum. Over there you have your IVC, the renal veins, all this stuff. Hepatic portal veins behind it. So IVC would be like here. This is all stuff like you can kind of see towards lab, or in the lab stuff. So body, L2 and aorta, whatever. We said tail lies anterior to left kidney, and then has to do with the spleen. So between the layers of splenorenal ligament within the splenic vessels. And then no embryo stuff. I know this was long. I hope it was helpful. I tried to break it down in a way that kind of connects things all together. I really think this study guide and then the lab stuff, definitely do the lab stuff first. If at this point the study guide is done, so if you did this first, whatever. But I hope this helped. I really do. Good luck studying, and have an incredible weekend.